Good morning, everyone. Welcome to the session, the patient-oriented session entitled Living with Liver Cancer, Patient-Centered Care and Support. My name is Ray Chung. I'm at Mass General Hospital and a member of the AASLD Patient Advisory Group who are convening this important session, which is designed really to provide patients, caregivers, and other healthcare professionals with a comprehensive understanding of liver cancer and its impact on patients' lives. We will have expert presentations as well as patient testimonials, and we're thrilled to have a couple of patient voices and interactive discussions aimed at fostering a better understanding of liver cancer and how patients can be better supported through their treatment journey. So without further ado, I'm pleased to introduce one of our co-moderators for the session, Jackie Chen, who will introduce the rest of the panel.
Thank you. Good morning, everyone. Thank you very much. Actually, it's good afternoon, right, isn't it? All right, it's 11 o'clock. It's really my honor and privilege to co-chair this session with Dr. Chung, a very famous physician at Mass General. And I'm Jackie, and I'm from Princeton, New Jersey. So today, I'm very, very honored to have two patients to do the testimonial. And this is what I do. I like to be patient first. So this time, again, we're going to have the patient do the presentation first. So, but you can see that this is what we're going to have today. I have a co-moderator with Dr. Laura Kulip, and then we'll follow by a patient testimonial from Tony Villiotti from Pittsburgh, Pennsylvania. That will follow by Lorrinda Davis from Oklahoma. And then after that, we have three expert presentations with Dr. Parrick from University of Michigan and Dr. Mehta from UC San Francisco. And then finally, Dr. Kulip will give us a poster tour of the latest development in the liver cancer research. So for Mr. Tony Villiotti, Tony was diagnosed with liver cancer back in 2017, and that was due to steatohepatitis and liver cirrhosis. So he actually received a liver transplant in 2018. His experience with liver cirrhosis and liver cancer led him to form a non-for-profit organization based in Pittsburgh, Pennsylvania, and he provides education and support for patients with related liver diseases. So without further ado, Tony, would you come up and start your presentation? Thank you very much.
Thank you, Dr. Chen. Thank you, Dr. Chen. Good morning, everybody. This just repeats what Dr. Chen just says. I'm from Pittsburgh. I am a cancer survivor and a liver transplant recipient. So I'm going to go through my journey in really three pieces. First, just very briefly, a general overview of my experience with liver disease. Then I will talk more about my liver cancer diagnosis and the treatments I underwent. And then finally, I'll wrap it up by talking about how it affected my life. These are my disclosures. All these disclosures really have to do with my nonprofit grants we've received. As far as my journey, I was diagnosed with a fatty liver in 2005. I was seeing my doctor on a regular basis because I was a type 2 diabetic. And at an appointment after some blood work, he informed me that my liver enzymes were elevated. I was also obese. So I was 59 years old, a type 2 diabetic, and obese. So I continued to see my doctor every 6 months, actually because of my diabetes. The fatty liver didn't sound like a big deal. He didn't make a big deal of it. He said lose weight. I heard that most days of my life, so it really didn't jump out as anything particularly to worry about. 9 years later, at an appointment, after he asked me to do an ultrasound, he told me I had NASH, which I had never heard of, and also probably cirrhosis, which really surprised me because I was associated cirrhosis with alcohol use or drug use. And I'd done neither of those. So at that point, I was referred to a hepatologist. She confirmed the cirrhosis diagnosis. Then 2 years later, I was diagnosed with liver cancer, and I'll talk more about that on the next slide. I underwent stereotactic body radiation therapy, and I had a transplant. My liver transplant. Actually, 1 year. I was called for the transplant 1 year to the day I was diagnosed with liver cancer. So I had the transplant. 5.5 months later, we formed our nonprofit because I came to understand that my experience with liver disease, not knowing much about it, not understanding potential ramifications, was really the rule, not the exception. So in March of 2017, I received my cancer diagnosis. I was scheduled for an appointment. I received a phone call asking to come in earlier, and I knew that was not a good sign. And sure enough, he indicated that my hepatologist indicated that I had liver cancer. About 6 months before that, I had had a scare where they thought I had cancer, but then concluded that I didn't. So this time it was for real. And so at that point, there was a lot of discussion about transplant. And transplant had been discussed with me before, but being a hard-headed Italian, I thought, there's no way I'm getting a transplant, and just kind of went on with my life. And I was still concerned about the transplant because I had read that after a transplant, your diabetes will get worse. And I expressed that concern, and my hepatologist had one very convincing sentence. She said, "We can treat you for diabetes. We can't treat you if you're dead." And so all of a sudden, I was all on board with the transplant. And so the discussion with the oncologist ensued. He recommended that I undergo stereotactic body radiation therapy. It was Dr. Karachenko from Allegheny General Hospital in Pittsburgh. He's one of the experts in that field. There was really no discussion of any alternative treatments, but he told me that procedure had about a 90% success rate, and it sounded good to me. So we decided to proceed. So that procedure, the SBRT, consists of 5 very targeted doses of radiation over a 10-day to 2-week period. Preceding that, there's a lot of mapping, computer mapping of the liver that needs to be done. So that took about a month before I really began the process. So we went through that, and the doctor said it would be 6 months really before he knew if it was successful. And the idea with the SBRT was not to cure the cancer, but to prevent it from spreading. Because if it spread beyond my liver, I would no longer be eligible for a transplant. So it was really considered a bridge to transplant. So at that point, I also underwent the testing to get on a transplant list, which is extensive. So it wasn't until June that I was on that I went on the transplant list. The summer went by. The 6 months, were up in October, and I was told the procedure was a success. The tumor had not grown and had not spread, so that was the good news. A couple weeks later, I get a phone call, and they tell me, we're continuing to look at your MRI results and your scanning results, and you have another tumor, and we're thinking we may have to repeat the SBRT. So I said, okay, well, if we need to do it, we need to do it. Well, the next day I get a phone call, and they said, well, looking at it, you really don't have enough good liver left to undertake the procedure. So we're thinking, that they were not going to repeat it, and you're close enough to getting a transplant that we think you can ride it out. So December kind of began a waiting game. At that point, under the rules in place at the time, I received exception points because I'd been on the transplant list for 6 months and had liver cancer. So I was kind of on the verge of getting a transplant. But it would be another 3 months really before I got the transplant when I got my second round of exception points. So and I'll talk about this more in terms of the impact of that had on my life. Before the cancer diagnosis, I really had very little in the way of symptoms. A little bit of fatigue. Every once in a while, I had some appetite loss, but I was really living my life as normal. I mean, was really not having an impact on the quality of my life. Once I got the transplant, the first few months were about once I got the diagnosis, it was still the same. I wasn't experiencing anything in the way of new symptoms. But that fall, kind of October turned out to be a good news, bad news month. The good news was that the SBRT was successful. The bad news was I started experiencing symptoms. I had ascites. There was fluid buildup in my abdomen and ultimately in my lungs. So they had to drain my stomach. The first day I went in, I weighed myself before I went in and after I got home, and I was 18 pounds lighter from the fluid that I had retained. The worst symptom I experienced, though, was hepatic encephalopathy. My wife was out one day. She returned home. I didn't know who she was. I didn't know where I was. I didn't know what year it was. I didn't know anything. My wife thought it was we never heard of hepatic encephalopathy. So we thought it was dehydration. So called 911. They came and I ended up spending 8 days in the hospital, and as I learned, ammonia had because my liver had deteriorated, ammonia had gotten into my blood system and gone to my brain, and and they said if my wife had been out longer, it could have been quite worse. I could have been been in a coma, and obviously that. Would have changed my life. But from that point forward, I experienced brain fog. I had a hard time reading a book. Ultimately, I had to stop driving, and that really began the worst part of life with liver cancer. And waiting, the combination of experiencing those symptoms along with waiting for the transplant. I mean, I'm normally a very laid back person, except when I'm watching my favorite college's football games. But just the emotional ups and downs, which is very hard on my wife and my family. One day I'm optimistic that I'm going to get a transplant and my life will be back to normal. The next day I'm writing my obituary and writing letters to my children. So just a lot of emotional ups and downs. So finally, on March 17th, 2018. 1 year to the day, I was diagnosed with liver cancer. I got the phone call, went in, had the transplant with no complications, was home eight days later, and have not been back to the hospital since. So, but just can't undersell the impact this has, not only on the patient, but also on their family. I mean, it affects everyone around them. So that concludes my remarks, and thank you for this opportunity.
Wow, that was a very, very extensive journey, and thank you very much, Tony, for sharing the story. Our next speaker for the patient is Miss Lorrinda Gray-Davis. Lorrinda was diagnosed with liver cancer back in 2017 due to steatohepatitis and also liver cirrhosis. She went through treatment for liver cancer and eventually received a liver transplant as well in 2019. She joined the board of Transplant Recipient International Organization called TRIAL, and also founded TRIAL Oklahoma chapter to support transplant patients. Lorrinda now serves in the Patient Affairs Committee for Region 4 of UNOS. And thank you very much, Lorrinda, for coming to share your story with us. And congratulations on your honeymoon, right?
Yes.
Thank you very much.
Yes, so I did get married on Halloween. They asked, hey, can we dress up in costumes? I said, no, you cannot. I'm going as a bride. So raise your hand if you've ever turned into Dr. Google. Have you ever? Okay. And how accurate was Dr. Google? I'm sure it was not accurate at all. And so I just want to, I guess I flipped it. So, okay. I want to talk about the 5 women up there. 3 of those women have had liver cancer. 4 of those women have had liver transplants. And the woman in the center is a donor mom. And we got to meet her and just embrace her because of, you know, the fact that she just lost her son and the fact that she was there. We wanted to show that what we do as patients when we get our, you know, when we get treated and we get better is help others. And so I'm going to talk about, here's about me, I'm alive. I get to. All that is I get to do it. And that is a wonderful thing because that is what it's about, is being here and being present. This is the overview of where I'm going to take you. I'm going to tell you about my diagnosis. I'm going to share a few things on my outlook, navigating the system, and just the treatment. So the shock of diagnosis, I will tell you that I was lying in a hospital bed, and the doctor comes in, and my aunt's sitting next to me, and he said, Miss Gray Davis, you have inoperable liver cancer, and you will die unless you get a transplant. And I hear that, and I've got tears running down my face. And I don't hear anything because I've got all this emotion, and the doctor turns around and walks out. And I look at my aunt, and I said, go get him. What did he say? Go get him. And he comes back in. And he says, Miss Gray Davis, you have inoperable liver cancer, and if you do not get a transplant, you will die. And I am just overwhelmed because I can't believe what he's telling me. There is no way this is happening. And I start going through, I'm going to die. I'm never going to see my daughter graduate college. You know, I don't have this. I don't have the money. I'm at the edge of a cliff on a mountain, and the ground has just crumbled. And I am sitting there falling, grasping on to whatever I can hold on to because it is so hard because I just lost total control of my life. And I had none. And so that right there kind of tells you exactly how we feel. I mean, the reaction to being told that is unmanageable. It's unmanageable. And I couldn't process it. Because you're just told, hey, this has got to happen, and it's like the mountain is too high to climb. I can't do this. Shocking outcome, I will tell you that I do. So I'm just going to tell you that, and I do make it. So, but my outlook. So this is one of my beautiful photos of how I looked at part of the process. Yeah, it looks lovely, doesn't it? So my thought was, I'm going to die, and why is this happening to me? I don't understand. And there were times I wanted to give up. And I told my aunt, I said, you know, I can't do this anymore. I can't. I'm done. And she would talk to me, and I would listen to a fight song. Does anyone in here have a fight song? I have a fight song for like everything, for like before I speak, but my fight song was actually called My Fight Song by Rachel Platten, and for some reason that resonated with me. We have someone in our group, his fight song is Roar by Katy Perry, and I'm like, okay, that's it, you know. But I encourage everyone to get a fight song because when I had to get in my feelings and I had to process, I needed something to lift me up. I needed something that could help me get through this. And so I would like to mention my stepdad died at 55 from liver cancer. I have a brother right now that has end-stage liver disease and a cousin that has lung problems and now cirrhosis of the liver. And there was a genetic component that we never knew about until after my transplant. But I had liver cancer, and so in this process, in my outlook was overwhelming. And then I had to literally get Outlook to manage appointments because it was the navigation. And so we think that, the plan is a straight line. And we're going to call the doctor, we're going to get in, and this is going to happen. And literally, it is not that way. It is like, with every step, it's like a 10-car pileup on the expressway. And you're just trying to get to the subway station. And it is hell because you don't know where to go and how to do it. And it all sounds simple, and there was no map. Dr. Google came in right here and said, hey, what's this? How do I do this? And there was no map that came up and said, you are here. And this is where you go. Not even just for instance, like, this is the main thing and you're going to experience different symptoms. There was nothing like that. And so I will tell you, so Tony said he had a taste, white eye. He had, that's what he had. I had a taste procedure. I mean, the only reason I didn't do my slides that way is because our journey is very similar in regards to the months, the dates, things like that. And so I just want to talk about, because when I see on social media, what I see is people that are like, well, does that work? I've got to have this test done, and does it work? Did it work for you? Because people are scared. And how do we, eliminate the fear is by talking. And so I don't encourage social media, but that's where people go. So my 10-car pileup that I'm stuck in, so this is a map that I absolutely love, and it's by Corey Schaffhausen from SRTR, and it's a transplant system. And so for me, this is like for everything that starts happening, for every part of, my liver process to get to treatment, it was like one referral, then conversation, and then a referral, and then more conversation. And the entire time, my liver cancer is growing, and I know that. And that is hard to fathom, because what my family told me? They said, get well, because my family did not know how to talk to me, because they don't know. And it's just that education. And so this is what I say, change your patient's don't, change your don't. Because my don't was, I got diagnosed. And that was it. I had to be aware of my diagnosis. I had to understand and change my outlook so my outcome would be better. And then navigating appointments, I had to have someone help me do that. And I had to have my support system around me. And I had to trust in the process. I had to trust the treatment and the transplant process, because that was my only hope. And so I want to go in and talk about what Tony and I both do. And I love it because Tony has a support group. We have a support group. I don't care. I mean, I do care about support groups and how well they're ran. But I do want to encourage the power of shared experience and how important that is. And it's important that, liver cancer is isolation. We live in fear of the unknown because no one that we know has had it. Or we hear my cousin's friend from that side of the family had it one time and I think he died. That's the kind of news that we get. No one carries the good news. And so encourage peer-to-peer support. We do have those meetings because it's a therapeutic effect, because when someone comes out from the other side, they can get that person that's terrified and take them through a journey and educate them. And they're not, in less fear, because fear is anticipation of, I don't know what's going to happen, and that's what fear is. And so the patients become more activated and more engaged, and they're able to actually go in, ask questions, get on the portal, ask the questions prior to going to the doctor. So that way the doctor has some time to sit back, find out the answers, maybe send them ahead of time, and everyone is it's better. And this is what we've done with our peer-to-peer meetings. We've done over 336 meetings for 42 months, 168 weeks, and we just did an IRB we did a survey that was conducted, and so we're getting ready to analyze the data and actually put it out in an abstract in a paper. And I'm going to ask a call to action for doctors. I've got some information for you all, and I know Tony has some information about our support groups, because I want to encourage you, and I want you to call the places that we work with, because if you do, they're going to say that they work for our patients. They help us as doctors. So I encourage education for families, for patients through peer support, because a doctor doesn't know what we know. They know how to treat us. You all know the process of how to treat the symptom, but just with our emotion that goes through it. It's mutually beneficial for the patient and for the health professional. So I think it strengthens the support system. And so my don't turned into a map. And that's what I would encourage you, is to just change the don't. And so I'm going to tell you that I got to see my daughter graduate college, which is amazing. I get to help all these people out, because these are different things that we do just throughout our process and our journey at Trio. And I got to be on a call last night with Trio Japan, which was pretty awesome, you know. And that was a very interesting, but I will tell you, I got married. You know, we spoiled that, but I got married. And so that's what I get to do. I get to be alive. I get to be here. And I just want to thank you guys for coming in and listening to what we have to say about living with liver cancer, because it is hard. And, you know, we just got to keep showing up and being there for each other. And patients need to make sure we're carrying the same message that we need to other patients, and, you know, encouraging them to, you know, be engaged. So thank you all, and I appreciate it.
Thank you so much. So thank you very much, Tony and Lorrinda, for sharing those very moving testimonials. We are now going to move to our expert panel. We have two very seasoned and well-known hepatologists who have really moved the field in HCC, really have dedicated their clinical and research to HCC. So I'm very happy to present Dr. Nihar Parikh, who is from the University of Michigan.
Thank you, Laura. This is a hard act to follow. Those are two great testimonials. Really gets at drills down to somewhat, you know, what our patients feel, but it's always hard to crystallize that, but you guys did a really good job of that, so I really appreciate that. So my name is Nihar Parikh, as Laura mentioned. Thank you for the introduction. I'm at the University of Michigan. I'm going to talk a little bit about navigating the healthcare system for patients with liver cancer. This was touched on by the talks before, but I'm going to talk some of the issues that I see on our end as well, and some of the kind of the research into this. These are my disclosures. So, an outline of today's talk. We'll keep it short but succinct. We'll talk a little bit about the patient journey for liver cancer care, which is near and dear to my heart for a couple different reasons, and I'll tell you in a minute. We'll talk about common barriers to care and consequences. We'll talk about liver cancer quality indicators. I think this gets into, you know, choosing where you get care, how you do that, and some of the gaps we have in this. And we'll talk about maybe some solutions, things we can do to make things better, and recommendations for patients. So why is this near and dear to my heart? So I'm from the East Coast. I'm from Baltimore. I moved to Michigan about 10 years ago. I didn't know, you know, kind of the Midwest is a little bit flyover for East Coasters. I don't know if there are many East Coasters out there. But when I moved to Michigan, you kind of realize what a big state it is, actually. There's actually this lower part where we all, you know, Ann Arbor is. And then there's this huge upper peninsula, which, you know, seems like another country sometimes. It's pretty close to Canada, but patients live there, and patients come from up there. So I have a patient, I just saw him last month. He comes every 3 months for surveillance. He lives in Iron Mountain. That's the yellow star there. And I Google mapped it before this talk, and that is a 7-hour drive in the state for this patient. Now, I told him, I joked with him, I said, I'm glad you don't live in Ironwood, which you can see is all the way on the edge there on the Wisconsin border. But that's what he drives every 3 months, 470 miles. It's only 3 turns, which is actually quite remarkable. But that's a lot. So he has to come the night before, gets his scans, comes, sees us, gets his labs, stays another night, drives back. So you can see this is a huge process. You got to have lots of things. So, you know, we provide specialty care. We try to do it. The patients try to come to us, but there are a lot of barriers involved in between, and it feels like hurdles a lot of times when we're trying to get patients into our system. When we talk about patient access, there are several issues, and you know, this is just a smattering of them. But transportation is a big one. We talked about that. The costs, not only of transportation, but missing work, et cetera, coming to see us, long distances, but even routine appointments for people who live close by. The availability, our access, you know, in the state of Michigan, all the medical centers are in the southeast part, the little corner in the southeast, but the whole state is so huge, there's really not much specialty care in the rest of the state. We think about things like dependent care. This is something that's underappreciated, I think, but you know, we have younger patients with liver cancer that have children. We have older patients that have parents. Who's going to take care of them when they're coming to see you? And then we also have a fractured healthcare system. Patients get admitted, patients have a primary care physician, they're totally outside of your system, they may not connect, people may not be talking, and that impacts their access to care if they have complications. How are they going to get back down to you? How are they going to see you? You know, these are issues. So what are some of the other consequences we see? You know, I'm not going to show much data during this talk, but this is one slide. This is a slide or a study from one of the national databases called SEER that looks at patients with liver cancer. And you know, this is published a couple years ago, and 64% of patients got no treatment. And we've seen this consistently in these large studies. Dr. Mehta and I are on an abstract during this meeting. In a privately insured patients, 42% got no treatment with a diagnosis of HCC. Now, of course, there's a selection bias there. Some of them, you know, may have not been able to get treatment for various reasons. They're too sick, but you know, it has significant consequences, and part of this is the navigating the healthcare system and the difficulty with that. And you can see here the, you know, those patients, not surprisingly, that got no treatment had the worst survival. This also leads to racial and geographic disparities in care. This is a study from Nicole Rich that looked at early stage detection disparities, and which it showed that as Black patients have lower rates of early stage detection than white, and it's about a 44% drop. If we look at rural-urban disparities, this has been consistently shown, but patients from rural communities have lower survival than urban and suburban communities, partially because of the barriers that I discussed earlier. There is a continuum of care in liver cancer that I think is important to realize. I think, you know, our speakers earlier today spoke to this a bit, but there's these challenges because there is a continuum here. First is recognition of liver disease. You know, a lot of patients who we see in clinic didn't know they had anything, and then they get diagnosed with liver cancer and liver disease all at the same time. About 25%, if you look at some studies, come in with, without recognition of their cirrhosis. Screening, you know, patients are screened, but not very many patients are screened. Less than 25% of patients undergo adequate screening once they have a diagnosis of cirrhosis or, you know, at-risk chronic hepatitis B. There's diagnostic issues. Diagnosis is often imaging-based, so that requires expertise, adequate imaging, et cetera, which I'll talk about in a minute. And then referral to care. How do you get the patients, once they're diagnosed, adequate care? And you know, I want to emphasize in this talk the value of multidisciplinary care for the treatment of this disease. There's, you know, many people involved, and we've talked about it with the patients earlier today, but you know, surgeons, radiation oncologists, interventional radiologists, everybody's got to be on the same team and the same page with sufficient experience to take care of patients. And within this continuum, there are these opportunities that are lost if these things are not conducted, right? You can prevent, you know, mitigate the risk of liver cancer if you recognize this liver disease early. If you're able to diagnose and screen patients, you can, you know, lead to early diagnosis. And these are some of the gaps we see. And the reason that I mention these is these are the things that are associated with better survival, making people live longer, getting to the, you know, curative therapies, et cetera, are, you know, these sort of things. So I think that's important. So I mentioned about screening. Less than 25% of patients are eligible patients are screened. We look at the barriers. This is a survey study that was done from UT Southwestern. Scheduling, costs, uncertainty of where to go, transportation. So these are kind of common themes about these barriers to navigating the system. This is difficult. Diagnostic difficulties. It is imaging based. This is a very unique cancer. We can make the diagnosis based on imaging, but you got to do it right. You know, multiphasic imaging, and you know, there's these liver protocols, but you know, some community hospitals, places don't know exactly how to do this, and they may not get it correctly. So that's difficult. Interpretation is also difficult. There's something called LIRADS, L-I-R-A-D-S, which is a system, which is detailed here. It's a little bit complicated, but it has size and how the tumor looks on different imaging. This is how we make the diagnosis. But your radiologist who's reading the scan has to know this and interpret it in this way. So this is a barrier that we often see from referrals that, you know, we don't know what this liver mass is. We have never heard of LIRADS. So this is one of the dissemination difficulties that we see in diagnostic difficulties. And when we get to treatment, treatment is incredibly complex. I don't show this to actually teach anybody anything about treatment, but it's just a lot. You know, I've had a couple patients ask, so what am I staged? What is my treatment? I show them this and they start laughing because there's a huge question. What does this even mean? You know, there's a lot of acronyms here. There's not really much there. So I think this is a very, you know, these are the reasons that there's so many barriers to liver cancer care there. Not to mention that many of these treatments require significant specialization, you know, and so I think that is something that is underappreciated out there in the community. So where do you get treatment information? I think we've talked about some of the support groups. There is some things online. Dr. Google, not so good. But, you know, the National Institutes of Health has a page, Mayo Clinic, Cleveland Clinic, some of these large health systems have pages that are there. There's some patient advocacy groups. I know there's some representatives from Blue Ferry here today and Global Liver Institute that do have information. But it's really difficult to get granular information specific to your case. You know, liver cancer is complex. I think patient support groups are great, but we do run into this issue where, like, you know, we see patients that are on online groups, but their situation is different than other people's situation. So it becomes, I think there's emotional support, but getting medical information, I think that's very difficult for patients. Actually, the ASLD, I looked at this the other day, has patient resources available, but unfortunately, there's nothing on hepatobiliary cancer. So I hate to call out the ASLD at their session, but there it is. How about where to get treatment? There's lack of transparency around centers of excellence for liver disease and liver cancer. Like, where do you go? And if you look at advertisements, people are always advertising, I have cyber knife, I have gamma knife, I have this knife, you know, and but patients don't really know where to go. Sometimes these are marketing things, and you don't actually know how they do, what their volumes are. There's no outcomes or volumes reporting, but this analysis from Texas shows that the more cases you see, the better your outcomes. This is especially true for localized disease, which is the top here, but even in metastatic disease, more advanced stages, volume matters. I've mentioned multidisciplinary care, but we don't really know what that means on some level. There's some guidelines in the latest guidance on this, but how do you know when you go to a center who your multidisciplinary team is? There's not really a lot out there. And there's no way of patients knowing who's part of the team. So I think this is a significant challenge to care. When we talk about multidisciplinary care, you know, we talk about medical specialties, palliative care for symptoms. We also talk about nursing, support. And this is the tenets of HCC clinical care, but it improves time to treatment, guideline concordant therapy, curative therapy receipt, and patient survival. So there are benefits to multidisciplinary care, but you know how transparent this is unclear. Or you know, it's not very transparent. And you know, this is beyond just seeing your local oncologist, right? This is really a team dedicated to this. When we talk about quality, you know, people are interested, like, how are your outcomes? And so the Practice Metrics Committee at the ASLD convened this, this practice metrics guidance on quality indicators for liver cancer care. This was published last year. This was done through experts, and we surveyed patients. And I'm not going to go through these, but you can see some of the recommendations, and you can look at the publication if you're interested. But right now, I mean, this is recommendations. This is kind of like the ivory tower approach where we have these things out there, but nobody's actually implemented anything, or they're not public reported. So patients, how do you know you're going to a high quality center? You don't know. And oftentimes, if people are not looking at their data, they don't actually know if they're a high quality center or not. So it doesn't even help to ask. So, there's these barriers. Now, what about some things that have happened that have been good? One of the things that have come out of the pandemic is the advent of telehealth. It does address several barriers. I can say from personal experience, we've had these, this has been a benefit that patients can call in for their surveillance appointments, and we can review everything with them without having to travel. And some of the things that I talked about, it can increase access as well. But there are caveats that may exacerbate some disparities. Technological literacy, which we've run into, access to high-speed internet, disparities in age, race, ethnicity, and socioeconomics are well documented, especially around COVID-19. And then what we've seen is variable investment by telehealth by health systems. So some health systems have a navigator, they can help you get online and everything, and other people just send you a link in your email and you have to figure it out. So I think this is one of the gaps that we see. So I'm going to finish up in the next couple slides. So what about navigating the health system? What are some recommendations? So certainly diagnosis and staging in this domain, certainly screening we know is important. Having systems in place, being an advocate for yourself to get screened if you have chronic liver disease, I think is important to understand what the guidelines are. Adequate diagnostic imaging protocols when patients are getting imaging to make sure that they're getting the right liver protocol. Making sure that the imaging is read using those criteria, I think is always important. This is something we run into not infrequently. When we talk about treatment, being considered for transplant, most patients with liver cancer have underlying liver disease that need to be, and transplant is the best treatment. So that's always some decision point. Are they a candidate for transplant or not? And based upon that, we kind of, move on. Volume matters, especially for earlier stage disease, as I've shown. There's not clear ways of figuring this out, but sometimes, we've had patients call and ask, how many patients are you seeing every year? They've done their homework. So that does happen. And then certainly the multidisciplinary team. I wish there was more transparency around this, and I think that's a call to action to have places really put this out there. So what could we do to make it easier? I think we can improve early stage detection testing. There's several initiatives underway to improve this, to make it more convenient and accurate. Right now, early stage detection is predominantly through ultrasound-based screening, which results in several barriers. But there are initiatives to make this more blood-based, which could be easier. I think the AASLD should partner with patient organizations, advocacy groups to have more patient-facing materials available online. This is a really big, huge hole, and it's a big opportunity for the AASLD. I'm glad that they're doing, I'll talk about this in a programming like this, but I think it needs to be on these, these sessions at the meeting. I think, something outside the box, but AASLD could develop Center of Excellence program for liver disease and liver cancer care. We have ways of measuring quality through EPIC now. We have quality metrics in place for both. This could be a certification process. You submit your data to the AASLD, they give you a certification, and then patients, that's something you can advertise, and patients know this is an excellent program. We've looked at their outcomes. This is, you lost your accreditation with AASLD, you should do better. I think the telehealth, I think has been a good thing, but I do think that there's gaps in how we implement this, and so I think broader implementation for liver cancer diagnosis and treatment, multidisciplinary tumor board reviews, et cetera, across telehealth. So I'm going to end with that. I really want to thank you. We want to continue patient programming such as this. I think this was a great session. I'm looking forward to Dr. Mehta's talk, but I'm happy to talk after the session with anyone. Thank you.
Thank you, Dr. Parikh. Our next expert speaker is Dr. Neil Mehta, who is from UCSF. He has been doing some groundbreaking work looking at some of these blood-based markers that will hopefully be used for not only detection, but prognosis in patients who have HCC.
Thank you, Laura, and everybody. I've really enjoyed this last this session. I think it's fantastic, and I'm so glad to be a part of it. And thank you for the invitation to speak today. All right, so my charge is to kind of chat a little bit about emerging strategies in the treatment of liver cancer. And so I'll try to go through these in three kind of groupings. We'll talk about different surgical options and criteria. We'll talk about some local regional therapies, and we'll finish by talking about some new systemic therapies. We are going to focus on HCC for time purposes, but obviously it's not the only important liver cancer, but there are many others, but HCC is by far the most common. So Nihar showed this earlier, and I totally agree with everything he said about it. It is busy and has a lot of different moving parts, and so it's very hard to understand, and so we're not going to spend much time, but he makes a really good point that if you tried to show this to a patient or tried to teach it to a medical student or resident, it would be quite challenging, and so there is a lot of complexity here. So in my mind, I really, in my clinics and with patients, I try to break it down, not so much by staging, but by treatment options. And the curative options that we typically think of are surgical. And the gold standard is resection, trying to cut a patient's HCC out if it's possible. Unfortunately, most of the time it's not. So if a patient doesn't have cirrhosis, then resection often becomes an option, especially if they only have one tumor. But once a patient develops cirrhosis, now they can have impaired liver function, and that is a time where if someone has their whole liver in and their liver's not working well, you can imagine that if you cut part of it out, it's really going to start working poorly. And so we do need to take into account liver function when we're deciding who can and can't tolerate a resection. And so we like to draw that distinction with patients where, okay, if you have really good liver function and, we may be able to do resection, but once you start, and trials A and B and C is a way to kind of focus on liver function. If they're having poor liver function, we think about transplant. So who is the ideal candidate for resection? Well, we have good liver function. We think about something called portal hypertension or high pressures around the liver. And so if someone's had their endoscopy and they have esophageal varices or they have a big spleen, we think they have high pressures. That is going to make the surgery harder for resection, and it's also going to worsen their outcomes. So we pay attention to that. We look at their bilirubin levels, and we hope that's normal. And then we know size matters. And so the larger the tumor, the more likely it is to recur. And so as your tumor becomes larger and larger, we get a little bit nervous about resection because we don't want to do something that's going to lead to the cancer coming back right away. And then our surgeons are getting better and better at techniques to really nicely not take out too much of your liver or make it a very morbid surgery for resection. And so especially if the tumor is on the left side or the smaller side of the liver, that might make the surgery easier for resection. It may be more amenable to either a laparoscopic or robotic approach. Now, one of the problems with resection is that you're leaving the liver behind. And that's the liver that kind of led to the cancer in the first place. And so recurrence is extremely common, meaning that the tumor comes back even though we thought this could be curative, up to 70% at 5 years. And we have all these different predictors that we pay attention to, but these are some of the things that we're thinking about when we're deciding, hey, can this patient undergo resection, or should they go down the transplant route? And one of the things we don't talk to patients that much about, we probably should do a better job of, is, okay, what is the background liver like? Do they have a normal liver, or do they have cirrhosis? Because this ends up being a very important predictor of tumor coming back. So you can see here that in a patient who has this kind of yellow-orange line has cirrhosis, they have, like I said earlier, up to a 70% chance of recurrence, whereas if you actually have a background liver with no scarring at all, they have a much lower rate of recurrence. I spend a lot of my clinical and research time thinking about liver transplantation for HCC, and obviously we heard two amazing testimonials about that process, which I really appreciated. Thank you for sharing. And in the US, we still use the Milan criteria, which is the gold standard here, but every other country has moved well beyond that, but that's okay. We'll come back to that in a moment. So we have specified upper limits of tumor burden, where we can or cannot offer liver transplantation for HCC patients in the US, at least for deceased donor transplantation. So this would, if someone has a single lesion, it can't be larger than 5 centimeters. If they have 2 or 3 lesions, none of them can be greater than 3 centimeters. And then the tumor, because we're doing transplant, we don't want the tumor to have spread outside the liver or spread into the large veins, typically the portal vein. Now, if a patient does undergo liver transplantation for HCC, as we heard about, we actually have really good outcomes. So 5-year survival over 80%, which compares extremely favorably with not only non-HCC indications, but also other other types of organ transplantation. And then, as I said earlier, resection, your risk of cancer coming back could be 60, 70%. But with transplants, because you're getting rid of the tumor in the cirrhosis, you have really low recurrence rates, somewhere in the 10% range, which is one of the reasons we like this therapy so much. Now, because we love this therapy, we want it to be fair. We really want it to be something that's accessible for as many patients as possible, and that wasn't always the case. And so we've made a lot of recent changes over the last few years as a policy perspective to really try to level the playing field. The first thing that we saw is that for many years, HCC patients, liver cancer patients, were getting over-prioritized. Which, for all of us would be great, but, you can imagine that if someone's super sick in the ICU without liver cancer and they're not getting access to organs at the same rate, that's not exactly fair either. So we really wanted to try to balance the access to transplant for liver cancer and non-liver cancer patients. And what we found is that if you put in a waiting time period, Tony talked about that 6-month waiting period, then you can actually more closely align rates of transplants for HCC and non-HCC patients. And so that was one nice thing that came out several years ago. And then another thing that we found, and this ended up being very troublesome throughout the community and throughout the country, there are lawsuits and a lot of other problems, but there was regional variation in access to transplantation, meaning that some of my patients in San Francisco were flying to Jacksonville or New Orleans to access transplant for liver cancer sooner, which is great for them, but most of our patients couldn't do that. And so we said, okay, if we're just going to kind of artificially give patients more access because they're not, we use something called the MELD score for liver transplantation, and it's a combination of your labs, and it's kind of how you might be placed on the waiting list. If we give liver cancer patients a MELD exception, we might as well give them differential priority so that their access to transplant based on where they live is similar. Meaning that it would make sense that if someone's in San Francisco, hopefully they wait around the same time as someone who's in New Orleans, for example. So that kind of makes sense. And what we noticed is for many years that wasn't happening. Patients in San Francisco, for example, and other what we used to call long wait regions had much higher rates of not making it to transplant than other parts. And so what we've done is we still, after waiting 6 months, we give what we might call an artificial amount of extra points, but we give differential points based on where you live. And that really has largely equalized waitlist outcomes for HCC patients throughout the country and HCC and non-HCC patients. So we think that's been hopefully a really nice step forward for us. The other thing about transplant HCC is we have biomarkers. And so a lot of you may have heard about alpha-fetoprotein, which is our main liver cancer biomarker. It's not perfect by any stretch, but it actually is a really good marker of tumor aggressiveness. So for an example, if I have 2 patients sitting in front of me with the exact same everything, liver function, tumor burden, but one patient's AFP is higher, that patient's probably going to do worse. And so in that case, we've noticed that the higher your AFP going into transplant, for example, the more likely your tumor is to come back. You can see in this multi-center study, if someone's AFP was in the 4 digits or higher, they didn't do well with transplant. And that's also shown very nicely in this summation of tumor burden and AFP. And so what we decided to do in the United States is create an AFP threshold, where if a patient would otherwise be a candidate for transplant, but their tumor marker was too high, then we say, okay, you can't access transplant until you show that your AFP has come down with some of the treatments that we heard about, with Y90 or SBRT or TACE, for example. The other thing we do in the United States very commonly, because we have these relatively restrictive Milan criteria, is a lot of our patients come in with more tumor than the Milan criteria. They might have a single tumor that's 7 centimeters, right? So how do we actually shrink those tumors into Milan or conventional US transplant criteria? So we use this process called downstaging, where basically we subject patients to these treatments that we heard about, and then hopefully their tumors respond and shrink, and now they're within criteria. And we think of it as like a selection tool. So if a patient responds to a TACE, or we heard about SBRT, and Tony had a good response, and so that actually portends a better prognosis. And so those are the patients that we think will do well with transplant. And so we've already heard about a lot of these options. My goal is not to go too in depth into them today, but I just wanted to highlight that there are a lot of different options that patients hear about, and it really, a lot of it comes down to kind of organ expertise. So Laura at Northwestern, for example, over 95% of their patients are treated with radioembolization versus some centers, don't do any Y90 at all. So there is a lot of variability in treatments that are offered. So one of the more common treatments that's offered is called TACE, we heard a little bit about. And so this is a selective embolization of the hepatic artery that's feeding the tumor. And so you can inject kind of things into the tumor that will kill the tumor. There's different ways to do this. You could do things the exact same way, but instead of injecting chemo, you inject radiation. So that's the Y90 radioembolization with a couple different ways to do that. And so there hasn't been a lot of head-to-head data in this space. We hear about TACE and Y90 and SBRT, and there's not a lot of trials, prospective trials, that are giving us input to say, hey, hepatologist, this or IR, this is the treatment that's the best. We don't really have much of that data. So Laura was part of this single center premier trial at Northwestern at her center that studied 45 patients who got either the radiation, the Y90, or the conventional TACE approach. And you can see here that in terms of time to progression, so how long after the treatment did it take for the tumor to kind of start progressing, Y90 did much, much better. And so that's super exciting, but then it would have taken hundreds of patients to actually show a survival benefit here. And so we think that Y90 may be better in terms of delaying progression, but we don't have really much data that says, hey, this is the treatment for you. This is the treatment outside of transplant or resection. This is the treatment that you should definitely do while waiting for transplant, for example. And so I just wanted to kind of show here that when we think about downstaging patients who are initially beyond that Milan criteria, that actually if you are beyond that criteria, but just barely, you actually do quite well after transplant if you've been downstaged. And so that's that red line. This is the 83% 3-year survival after transplant versus 79%. And these were not statistically different. This is our national database. And so we actually now have national criteria that say, okay, here's who can get automatic exception or priority, even if they initially exceeded the Milan criteria, if they're successfully downstaged. And then downstaging has also been incorporated into this latest staging crazy classification. In the last few minutes, I just wanted to chat about what happens if you're in the advanced stage. So what happens if a patient comes in who either does have vascular invasion or cancer that's already spread outside their liver into the lungs or other places? Unfortunately, their survival is worse, but we never want to say, but the good news for this kind of patient, but the good news is that for many years, we only had one option. We had something called sorafenib, which is was kind of the only option for about 10, 11 years, and it had side effects, and it really only extended life on average by a few months. And so, unfortunately, that was really the only option that we could offer to patients until the last few years, where we've had this explosion of excellent treatment. So really the landscape hasn't just changed for early stage patients, but has also really changed for later stage patients as well. And so this is a kind of the first study that really got us excited about combination therapy. A lot of people have heard of, either from their providers or from television, about this new class of cancer therapy called immunotherapy, which is not chemotherapy. It's actually basically making the body learn to recognize cancer cells as foreign and then be able to finally target them. And so this trial was a combination of immunotherapy, a checkpoint inhibitor called atezolizumab, plus something called Avastin, which is a vascular growth factor agent called bevacizumab. And basically what it showed is that this combo was much better than sorafenib. And so that's super exciting. That just came out a couple of years ago, and so this is one of the new first-line therapy options. And then more recently, last year, we have a second really good combination first-line option for patients who have advanced stage cancer called durvalumab. This is from the Himalaya trial. We call this the STRIDE regimen, where patients would get a single dose of this tremelimumab infusion and then get maintenance dosing of this durvalumab treatment. And it showed, again, to be better than sorafenib. And so, obviously, we're not kind of going through all this, but I just wanted to show this slide because if you had showed a slide for systemic therapy of HCC 5 years ago, it would just have a box that said sorafenib, and now we have multiple option boxes with multiple colors and all this stuff, and people in med-onc, people are really excited, and we should be, because we're able to help patients who used to only live less than a year with advanced stage liver cancer now live on average over 2 years. And some patients who have a really good response can live many, many years. And we're seeing patients who have a kind of a complete response. It's not common, but a complete response to some of these therapies and living a long, long time, and sometimes even being able to access other therapies because of their response. So super exciting time, even for patients with unfortunately advanced stage liver cancer. So I think my time's up, but thank you very much for listening.
Thank you very much, Dr. Mehta. Let's see, how do we get to the next one?